see. I'll let you take a look at that for a second, then I'm gonna give you guys a question. So the question is, after you have reviewed the film, what's the most appropriate next step? Should you give approval to use the line? Should you draw blood gases off the line and the wrist at the same time? Should you remove the line? Should you consult vascular surgery to remove the line for you? Or should you consult interventional radiology to confirm the position of the line? I'll give you a little bit of time to enter your answers. Okay, about 15 more seconds.
Morning. Morning. I'm David. I'm the new rehab intern.
Oh, awesome. Hi, David. James. Good to meet you.
Okay. I'm going to end the poll, and I'm going to ask if people can mute their microphones if they're not going to be speaking. So the majority of you actually went for choice 4, consult vascular surgery to remove the line. The correct answer in this case is actually to draw simultaneous blood gases off the line and the wrist. Turns out that patients with Down syndrome often have a persistent left superior vena cava. So this line may very well be in the appropriate position. And the way to confirm that is to get simultaneous blood gases off the line and the wrist. And I'll take you through that again in just a little bit. So this is going to be a very common issue for you as an intern, is confirming the appropriate position of various lines and tubes that get placed in your patient. For triple lumen catheters, the goal is for the tip of that catheter to reside at the cable atrial junction. And that is usually present where the right mainstem bronchus crosses the right side of the heart. That is the typical location. That is where you want the tip of a triple lumen catheter to be. Dialysis catheters will not always make it to this location, nor will Cordis catheters, because in some cases they are too short. So here is a this is actually a PICC line, but it's the same principle. And I'll just have you enter into the chat what you think, whether it's okay to use the line in this patient or not. Getting a lot of votes for no coming in on this one. This line's actually probably okay. Many of you are picking up on the fact that the tip is residing in the left side of the chest, which always raises concern about the fact that it's in the aorta. But there are several clues in this film that suggest that it may be fine. This patient has dextrocardia. The left hemidiaphragm is actually higher than the right, and there's evidence of bronchiectasis. So this patient has situs inversus associated with Cartagena syndrome, and this line tip is probably in a correct location as well. So there'll be some situations in which you're not sure whether the line is in the right position or not. And there's two things you can do to try to confirm before you do anything else. The first is get blood gases at the same time from the central line and from a known arterial site like the radial artery. If those gases agree with each other, it is an arterial line placement, right? But if the PO2s are markedly different when they're drawn simultaneously, your line is probably in the vein. But the gold standard is going to be to transduce a pressure waveform off the line. And if you get a venous pressure waveform, you're fine. Now, ideally, you're doing this with a pressure monitoring device during line placement itself, but occasionally those may not be available, or you may still be unsure. Feeding tubes are another common tube for which you're going to be asked to confirm the position over the course of your internship and residency. And what you're looking for feeding tubes is that they should come down the midline all the way to the diaphragm. They're generally the tip should reside below the diaphragm. The tubes will then course generally to the left side of the stomach and then follow the greater curvature around. And you would ideally like the tip to be pointing away from the gastroesophageal junction. And the tip of most feeding tubes is readily identifiable because it's quite radio-opaque. It's a little less easy to identify when someone has a nasogastric or orogastric tube because it doesn't have this very radio-opaque tip. Okay. Do not stress very much about whether the tube is in the duodenum versus the stomach. It does not actually change the risk of aspiration, but these are the principles that you are looking for in an appropriately placed line. So here is a feeding tube that's been placed in a patient. I want you to take a look at that. You can just enter your answers into the chat as to whether you think this tip, this line or feeding tube is okay to use. Yeah, a bunch of people going for no in this case, and I agree with you. This is probably not a line feeding tube that should be used. This feeding tube comes down the midline appropriately, enters the stomach, but then loops back somewhere in either the stomach or the duodenum, and the tip is pointing back up towards the gastroesophageal junction. You'd be wary about using this, and you'd want to ask the nurse to try to reposition it and then to repeat the film. Endotracheal tubes. The goal with an endotracheal tube is that you want the tip of the tube to be below the clavicles and about 2 to 4 centimeters above the carina. Endotracheal tubes that are too low run the risk of causing a main stem intubation, whereas if they're too high, it increases the risk that you might have an unplanned extubation. So this would be something you'll be checking immediately post-intubation on your patients. The RTs do a good job of checking this on their own, but you should be looking at this as well. All right, we're going to go on to our next case, but before we do that, I'm going to stop and see if there are any questions that pop up in the chat. Doesn't look like any are coming, so we'll move on to the case. So this is a 36-year-old female with a history of unprotected intercourse with multiple partners, as well as a history of injection drug use, who presents with sudden worsening of dyspnea that's been developing along with a dry cough over a 3-week period. Here's the chest film done on this patient. I'll let you look at that for a little bit. This, by the way, is external to the patient, so don't stress too much about what that very dense structure is. And then the question we're going to ask, and I'll put up a polling question about this, is you've reviewed the film, what's the most appropriate thing to do at this point in time? Should you administer ceftriaxone and azithromycin, consult the pulmonary service for bronchoscopy, order a CT pulmonary angiogram, start furosemide, or order a upright chest radiograph? Okay, I'll give you about 15 more seconds. All right, we're going to end the poll, and I'll share the results. The majority of you did go for the correct answer in this case, and that you wanted an upright chest film. This patient has multiple risk factors for HIV, including unprotected intercourse and injection drug use, which raises concerns about pneumocystis pneumonia, and that would fit with a history of several weeks of worsening dyspnea. There are, in fact, diffuse bilateral opacities in this individual, which would fit with a diagnosis of pneumocystis. But one of the complications of pneumocystis is the development of a pneumothorax. The cysts that are present in pneumocystis pneumonia can rupture, causing pneumothorax. This person is supine, and they have an important finding of pneumothorax when radiographs are taken with the patient in the supine position, known as a deep sulcus sign. And I'll go over this again. If you weren't sure if this is a pneumothorax, the way to confirm would be to get an upright chest film, because the pneumothorax would change position. You'd be able to see it more clearly. So now we're going to talk about the issue of air that shouldn't be where it is in a chest film. And this is various forms of barotrauma. We'll start with pneumothoraces. There are some pneumothoraces that are going to be blatantly obvious to you on a chest film. You're going to see some densely consolidated lung out to a clear white line, and then hyperlucency on the opposite side of that line. So it's very, very obvious in some cases. Okay? There are some situations, however, in which a pneumothorax may be much more subtle because it's either very small or there's something about the projection of the film. So in this case, when you first look at it, you may not appreciate that there's a pneumothorax, but when you look more carefully, there is lung markings out to a distinct line and an absence of lung markings on the other side of that line.
Hey, Andy, can I interrupt you for 1 second?
Yeah.
There's a question in the chat. I don't want to get too far along. Is the deep sulcus sign usually present only when supine?
Yeah, actually coming to that issue again, because we're going to review the presence of what happens when patients are in a supine position, is that you can sometimes be fooled. You won't see the obvious findings of pneumothorax where you have lung markings out to a white line and then lucency on the other side. When patients are supine, the air can sometimes be trapped in a different location, and what you end up seeing is a deep, narrow, and lucent sulcus when compared to the other side. Okay? And this is generally going to be present when people are in the supine position. When they're upright, you often see a more obvious appearance of a pneumothorax. That is not universal, because sometimes pneumothoraces are small or they're located in an anterior position on the chest and you don't really even see them on a plain chest radiograph, and they only get picked up when you get a CT scan. This happens a lot in the trauma ICU. If you are not sure about whether there's a pneumothorax, you can repeat the film with the patient in the upright position if it's feasible to sit them up, or you can think about using chest ultrasound as well. Okay? So ultrasound is something you can become much more facile with over the course of your residency. It's increasingly being used in the ICU. What you do when you do ultrasound for ruling in or ruling out pneumothorax is you're looking for what's called pleural sliding. You identify the lung, you identify a clear pleural line, and then you go into M mode. And when you go into M mode, what you should see is what's known as the sandy beach sign, where you have kind of this area of lines above the clear white line here, which is the pleural stripe, and then this kind of more granular area here. This is a sandy beach sign. It tells you that there is lung sliding going on, and this rules out a pneumothorax. If you see instead what's called the barcode sign, where despite putting the M mode right over the area where you have the pleural stripe here, you just get a whole series of lines all throughout the M mode portion. That tells you there's something wrong in the pleural space. It doesn't confirm that it's a pneumothorax. It could be a pleural effusion, it could be pleural thickening for some other reason, but there's some other pleural space abnormality. So here's another patient who's got a problem in the form of barotrauma. What's wrong in this chest radiograph, aside from the obvious diffuse bilateral opacities that you would see in a patient with ARDS? You can put your answers into the chat. Good, so people are picking up on a couple of important findings here. The soft tissues should look nice, homogeneous, and white like this, but when you look up in the area of the neck, there's a lot of lucency, and lucency in a chest radiograph is air. You also look in the middle of the chest, you see this rim of lucency around the heart here, extending up this way, and you can see a little bit of lucency in here in this thin little piece of tissue in this location. Right? These findings are consistent with pneumomediastinum. When people have ARDS and they're requiring very high pressures to ventilate them, air can rupture out of the alveolar space, track along the bronchovascular bundle into the mediastinum, and extend up into the neck. You can also sometimes see this when people fall, like on their back, for example, and their glottis was closed at the time that they impacted the surface. They'll get a sudden rise in their intrathoracic pressure, and they can develop pneumomediastinum as a complication. Now, one of the things that was raised in the chat was, could this be pneumopericardium? And it sometimes is a little bit hard to distinguish. This patient in this film has pneumopericardium. The way you distinguish it in pneumopericardium, you're not only going to see air along the side of the heart, but the air starts to track down around the bottom of the heart like this, okay? It can be subtle, not always easy to distinguish, but that's what you're looking for to separate pneumomediastinum from pneumopericardium, because pneumomediastinum should not cause air down underneath the heart like that. What's wrong in this film? You can enter your answers in the chat as well. Okay, good. A lot of people picking up on the key finding here, which is that this patient has pneumoperitoneum, air underneath the diaphragm. In general, this connotes the fact that the patient has an abdominal emergency. They have perforated some hollow viscus. So a patient who develops abdominal pain and has air underneath the diaphragm, that's a problem. You need to be consulting the general surgeons. Air can, however, be seen in the abdomen following either laparoscopic surgery or percutaneous endoscopic gastrostomy tube placement with either interventional radiology or the gastroenterologist. So in those cases, air would be allowed. But in other situations, if you have air underneath the diaphragm, you need to be thinking about the possibility of a perforated viscus. Now, one of the questions that often comes up for people is, how do I distinguish pneumoperitoneum from air that's in the stomach or the colon? And it's not always easy. If that air is located under the right hemidiaphragm, it's going to be pneumoperitoneum. But when it's located under the left hemidiaphragm, it's a little more subtle. In general, the diaphragm is actually a very, very thin structure. So when you see lucency beneath a really thin structure, that should raise concern that this is pneumoperitoneum. When you have a gastric air bubble, you're going to have the wall of the stomach and the diaphragm together, so that line of opacity is going to be thicker. And you can appreciate that it's thicker here, for example, than in this area here, thicker here than it is in this area over here. And then quite often, if it's the stomach, you'll see this kind of irregular border to the lucency underneath. And if it's colon that's trapped up underneath the diaphragm, you'll often be able to appreciate the fact that there are haustra there. So those are some of the things that you can do to distinguish pneumoperitoneum from air that's in the stomach or the colon, but it is admittedly going to be subtle in some cases. Okay, we're going to move on to the next case. I'm going to stop there, though, and see if people have any questions. Okay, it doesn't look like any are coming up, but if something comes up later as I start talking, please just put it into the chat and then Gabby and I will catch it. So in this case, you have a 62-year-old female who was intubated for respiratory failure secondary to a left lower lobe pneumonia. She had a right subclavian central venous catheter placed after several unsuccessful attempts on the left. And then 4 hours later, you called to the bedside due to sudden worsening of hypoxemia and an increase in the static pressure on the ventilator. And here's the chest radiograph that you obtain on this patient. I'll let you look at that for a second. And then the question, we'll have a polling question about this as well, is what are you going to do in this situation? Okay. So should you order a chest CT scan? Should you do a thoracentesis on the left? Should you place a chest tube on the left? Should you start chest physiotherapy on the left? Or should you call the pulmonary service or your MICU attending to do bronchoscopy? Okay, we'll go for about 15 more seconds. Okay, let me share the results with everyone. So the majority of people wanted to place a chest tube on the left, smattering of people going for some of the other answers. The correct answer in this case is to do chest physiotherapy on the left. Many of you are rightly concerned that after multiple failed attempts to place a line on the left, that this patient could have a pneumothorax. The patient also has pneumonia, and patients with pneumonia produce a lot of mucus and sputum, and as a result are at risk for plugging off one of their mainstem bronchi or some of the segmental bronchi that could lead to either segmental, lobar, or whole lung collapse. In this case, this patient has whole lung collapse, and I'm going to take you through how to recognize that and distinguish it from a massive effusion on a chest radiograph. So we're going to talk about this important finding that you need to be able to recognize. So in general, if the lung or a portion of the lung, and usually it's a lobe, when these collapse on a chest film, you're going to see several key findings. You're going to see tracheal deviation towards the area of collapse. The mediastinal structures, and in particular the heart, are going to shift in that direction as well. The diaphragm quite often shifts up. You won't see any vascular markings on the side of the collapse. Occasionally, the other lung can actually move across the midline towards the collapse. And you might also see some evidence of like a large mass that is responsible for the collapse of the lung as well, although these latter two things are not always going to be present. Now, you're occasionally going to see patients who have a unilateral lung whiteout, meaning an entire hemithorax is densely opacified. And there's a pretty short differential for that. It's either a massive pleural effusion or the entire lung has collapsed down. And I'll take you through how it is that you can distinguish these two. When someone has a massive effusion, the trachea is going to remain on the midline or deviate to the opposite side as you see it doing in this case. Notice that the heart remains in its normal position. If it does move at all, it's going to deviate to the side opposite of the opacity. So in this case, the massive effusion is pushing everything towards the left side of the patient's chest. That's in distinction to whole lung collapse. Now the trachea deviates to the side of the opacification. The heart shifts to that side as well. Notice that you no longer see the heart to the side of the spine here that you should see. This is actually pulmonary artery in this case. The heart itself is missing. And then there's another finding that you may see known as an airway cutoff sign, and I'll show you that in a second. And also how the left hemidiaphragm is increased compared to the right here, and that's because of the volume loss. The diaphragm has shifted up as well. Now there's a sign known as an airway cutoff sign that also helps you identify collapse as opposed to a massive effusion. Here you can see the endotracheal tube in the trachea. You get down to the main carina, the left mainstem bronchus comes off here, and notice that it just abruptly ends. Right? I'm going to take away that last thing. All of a sudden, amidst this opacification, this lucency stops, the airway abruptly ends. That is due to a large mucus plug or blood clot that is occluding the airway at that point. It's an important finding that fits with plugging and collapse rather than massive effusion. Now, there is another form of collapse which you're going to see, and that is right upper lobe collapse. This generally happens for one of two reasons. The more common reason you're going to see is that an endotracheal tube is too deep. When endotracheal tubes are too deep, they extend into the right mainstem bronchus more commonly. And because the right upper lobe takes off from the right mainstem bronchus very quickly after you enter that airway, it's easy to block the right upper lobe bronchus and as a result not ventilate the right upper lobe. A lot of patients who have lung cancer, though, will also have proximal masses. And when those proximal masses occlude the right upper lobe bronchus, you get right upper lobe collapse as well. What you'll see in those cases are opacification over the right upper portion of the chest. The minor fissure, which is typically present in this location here, right around the middle of the chest, will actually shift upwards, and you'll see a curvilinear structure in this location here. Okay? And then what you'll commonly see is tracheal deviation to the side of the collapse. So notice that our minor fissure has moved up. You see a curved line here, and you have tracheal deviation. Those are the things that fit with a right upper lobe collapse in this particular situation. There are characteristic findings for left lower lobe collapse, right lower collapse, right middle lobe collapse, but that's a little bit more detail that we're going to need to get into here this morning. If you look at that chest radiograph resource that I highlighted at the start of the talk, there's more information about the findings in other types of lobar collapse in that resource. But this is the most common one you're going to see, so I wanted you guys to be able to recognize that. Okay. We're going to move on to our next case, and I'll stop there and see if you guys have any questions before we do so. It was asked if I could put that resource in the chat. I can't actually access it right now. And what I'll do at the end of the talk is I'll go back to that slide at the very beginning so you can see that one.
I can also try sending it out to the intern listserv. I also just want to make a quick comment that oftentimes there are questions for Dr. Lux. I know that it may feel harder to pose those questions on Zoom, and just encourage you that if you have the question, likely one of your colleagues has the question, so don't be shy.
Okay, wait a second, see if there are any further questions that come up. Okay, it doesn't look like any others are coming up, so we'll move on to our next case. This is a 55-year-old male who presents with increasing dyspnea and left-sided pleuritic pain one day after falling off a horse, and you get a chest radiograph. Let you spend a little bit of time looking at that before we move on to a question. So here's the question for you, and I'm going to put up a question so we can poll on this one. So you've reviewed your film, and what's going to be the next most appropriate intervention? Should you start ampicillin cell back down? Should you order a chest CT? Should you start chest physiotherapy on the left side? Should you perform chest ultrasound? Or should you consider placing an epidural catheter for relief of pain associated with rib fractures? Go for about 15 more seconds. Okay, so I'm going to end the poll. I'll share the results there. The majority of you went for the correct answer in this case, which is chest ultrasound. A good number went for a chest CT scan too, which it's a reasonable thing to do, but I think the most appropriate intervention in this case would be, in fact, to do chest ultrasound. It's important to pick up that this patient's film was done with them in the supine position. They have this kind of unilateral, hazy-looking hemithorax, which when a patient is in the supine position and has that radiographic appearance, that's suggestive of a layering pleural effusion. So in other words, a pleural effusion that is lying underneath the lung with them in the supine position. You're certainly right to think that this patient could have a hemothorax. They could have rib fractures. Rib fractures are often very difficult to identify in plain chest radiograph. Chest CT is way more sensitive. So that might be a reason to consider a CT scan, but I think the more appropriate thing to do here to start would be simply to order a chest ultrasound. So we're going to talk about pleural effusions and how to recognize them on films. Now, in general, the lung and the lung marking should extend all the way out to the chest wall, although you would generally see tapering of lung markings out in the very periphery of the lung. In some cases, you'll see lung markings extending out to an area of opacity that exists between the lung and the chest wall. This finding is known as pleural separation. It's abnormal. It tells you that something is in the pleural space, but that could be fluid, cancer, inflammatory tissue of some sort. Something abnormal is there. It's not specific for pleural effusion, but it just tells you that there is a pleural space abnormality. Now, some pleural effusions are going to be obvious, and the classic appearance that you'll see when a patient is in the upright position, because the fluid is going to form a column, you're going to see a very dense area of opacification that obscures the hemidiaphragm, obscures all or part of the heart border, depending on how much fluid is there. And because that fluid is forming a column when the patient is in the upright position, you quite commonly see the classic finding of a meniscus sign. The patient also has a smaller effusion on this side, as you can recognize based on the blunting of the costophrenic angle. Now, in this case, this may all be due to heart failure, and you're suspicious of the fact that this patient has heart disease because you've got sternal wires, a prosthetic valve, as well as an AICD, possibly a pacemaker. So they'd have reason to have heart failure in bilateral transudative effusions. If you did see a new large or even a new unilateral pleural effusion in a patient that's not otherwise explained by other aspects of their clinical history, you need to do thoracentesis in this individual. Now, when patients are in the supine position, pleural effusion is actually going to look different. When they go supine, the fluid is going to layer out underneath the lung. And so when you shoot the radiograph, you're getting lung tissue over the fluid itself, and you do not see that characteristic appearance. And quite often what you're going to see is just a very hazy hemithorax when compared to the other side. But notice that you can actually appreciate lung markings through all of that haziness. So when you see haziness, but you can still appreciate lung markings through there, and the other side looks pretty normal, be suspicious that that is a pleural effusion if the film was done with the patient in the supine position. You could always repeat it with them upright, obtain a lateral decubitus film if they can't be upright, or just use bedside ultrasound. Now, when patients are in the semi-upright position, and this is something that happens quite commonly in the ICU, it can be a little harder to distinguish effusion from a pneumonia. And I think what you'll see in that situation is you tend to get a gradient of opacity. So here's a patient who's in the semi-upright position. And notice that there is very dense opacification here, but as you move further up in the chest, it gets a little darker, darker, darker. So there's more lucency up in this area. So it goes from very white to less white. That's the characteristic appearance of a large effusion when someone's in the semi-upright position. Ultrasound was performed, a chest tube is placed in this individual, and now you can see what happens when you remove the fluid. They still have opacification. This ended up being a hemothorax, so this is pulmonary contusion that was left over after the hemothorax was drained. But notice you can see the diaphragm, the heart border itself right now. Okay? So in some cases, effusions can be a little more subtle and difficult to identify compared to the patient who is bolt upright, as the dense opacification associated with the meniscus sign. And then finally, what you'll sometimes see are loculated effusions. Notice that we've got lung markings extending all the way out to the chest wall up here, but down here, the lung markings extend out to this area of opacification. Now again, this could be a mass, it could be fluid, it could be some inflammatory tissue. You're going to need either ultrasound or chest CT to help you clarify it, but there's clearly something wrong in the pleural space. In this particular patient's case, this happened to be a loculated effusion due to an empyema. So that actually needed to be drained. It's not something you can drain with thoracentesis. You're going to need the help of surgeons in all likelihood because it is a loculated fluid collection. Okay. We're going to go on to our last case, and I'm going to stop there and just see if there are any questions before I do that. Okay, doesn't seem like any are coming on. Okay. I'll wait one more second. So one question is, how do you order chest physiotherapy at UW? It is a respiratory therapy consult in Orca. It's pretty simple to actually do. I would recommend that you also just go chat with the respiratory therapist in person so that they see that order in a timely manner, but that's the way to get it into the system. Okay, our last case is a 65-year-old male who's admitted for evaluation of chest pain. His electrocardiogram and serial cardiac enzymes are negative, and you're called to see him at night because he's having more pain. Sorry, oops. He's got an oxygen saturation of 92%, breathing ambient air. And then you go back and review the chest radiograph that was done in the emergency department, and this is what you find. So I'm going to put up a polling question for you. So you've reviewed the chest film, so what should you do next? Should you give this individual some intravenous furosemide? Should you start intravenous levofloxacin? Should you order a stat echocardiogram? Should you order a CT aortogram? Or should you order a CT pulmonary angiogram? Okay, 5 more seconds. All right. There was a spirited competition between the CT angiogram and the stat echocardiogram, but it looks like more people went for the CT aortogram in this particular case, which is in fact the correct answer. When things don't make sense in a film, I think one of the good things to do is to just try to follow where all those shadows go and what do things connect up with. And when you follow some shadows around here, you'll see the aortic knob here and the line comes down and maybe it, oops, sorry. Maybe it goes down this way, but I think that's the heart border. And all of a sudden you follow it out this way and then follow it back that way. That's really suggestive of the fact that this patient may have a problem with their aorta, either a dissection or a large aneurysm. And the way you're going to evaluate that further is to obtain a contrast-enhanced CT. The difference between an aortogram and a pulmonary angiogram is the timing of the imaging relative to when the contrast is given. In an aortogram, they're going to wait longer for the contrast to circulate through to the arterial part of the circulation before the images are taken. So what I always like to conclude with some chest pain radiographs that you don't want to miss, because sometimes there's some important diagnoses that get overlooked if you're not doing a good thorough review of the film. So for the normal aorta, you should see the aortic knob on the left side of the chest. There are some rare anatomic variants where it may be on the right side. It's generally not too large. Shouldn't be much larger than like quarter or a $50 coin. And then you should be able to track the aorta down through the chest. And it tends to hug pretty close to the left side of the thoracic spine. In older individuals who've had longstanding hypertension, you can sometimes see what's called an ectatic aorta, which will extend out this way. Doesn't necessarily imply that they have dilation as seen in dissection or aneurysm. Now, you will see some other cases, however, where there is markedly abnormal aortic shadow on the film. So here you have this overly large aortic notch, and then this large structure here that's extending down through the chest. Here again, a very, very large aortic notch that extends all the way down as well. Now, just looking at a plain chest radiograph, it's very difficult to say that this is an aneurysm versus an aortic dissection in all cases. Sometimes the history is going to help you tell them apart because dissections are typically associated with rapid onset, very sudden tearing pain that may extend from the chest down into the abdomen, often felt between the shoulder blades in the back of the patient. But in other cases, it can be a little more subtle. So the way you're going to actually distinguish those two would be with CT imaging, ordering a CT with an aortic dissection protocol.
Andy, I wonder if you could
Yeah.
pause for just a moment and address
Sure.
questions in the chat about when you would get CT or not in the setting of a dissection.
When you would get an echo?
I apologize. So the question is there a situation where you wouldn't send the patient to the CT scanner and instead go to the OR somewhere else first? Would you always get a CT first?
Yeah, the vascular surgeons are gonna, or the CT surgeons are always gonna wanna see a CT first. When people have dissection, the blood doesn't rupture out into the mediastinum or into the pleural space. The blood is dissecting its way through the wall of the aorta, and they need to see a CT with contrast in order to define the extent of the dissection. They wanna know if there's involvement of the ascending aorta, or if the dissection is just confined to the descending aorta, because that markedly changes the management. Ascending aortic dissections typically require surgical management, a very complicated procedure, whereas descending dissections may be just managed medically or managed with endovascular approaches. So a CT is generally going to be indicated in that situation. Echocardiograms are part of the evaluation when you've identified dissection because it helps you look at the root of the aorta and whether there is any aortic valve involvement as well. But the CT would be indicated.
Great. And a follow-up question is, should we order CT on any patient with chest pain and an aneurysm?
I think it depends. I mean, there are going to be some patients who are known to have aneurysms. And if it's stable appearance on a plain chest radiograph, you have a good other explanation for the presence of their chest pain, such as this clearly a myocardial infarction, you might hold off on a CT in that situation. If you don't have a good explanation and there's some features of their presentation like the sudden onset of a tearing pain, then you would order a CT in that particular case. I think it's really, there's no hard and fast answer to this question.
Great. Before we move on, for folks who posed the questions, is that helpful clarifying information, or are there still outstanding questions? Okay. All right. Sounds like we're good. Thanks.
Great. So a couple more chest pain films. So here's a patient with chest pain 3 days after a fall. So just put in the chat if you see any explanation for what could be going on. Give some time for some other thoughts. right, so a couple of thoughts being entered about. There was, Shiv did put in the correct thought here, is that if you look at the subcutaneous tissues on the left, again, subcutaneous tissue should look very dense and homogeneous and white like it does in these areas. Down here, there are these areas of lucency in the subcutaneous tissue. There may be some lucency within the pleural space here, very difficult to see. And sometimes pneumothoraces themselves can be quite small. If you see subcutaneous emphysema in an individual who has not just had a tube placed through their chest wall or some other violation of the skin that would have allowed air into that space, this is generally denotes the presence of a pneumothorax or pneumomediastinum until proven otherwise. And in someone who had fallen, this would be a good reason to look further for rib fractures and pneumothorax. And so you might consider, this patient came into the ED and had this finding, this patient would likely get a chest CT scan to look for either a subtle pneumothorax or rib fractures. Here's a patient who presents with back pain, dyspnea, and fever over 2 days duration. See if anyone has any thoughts here. It does not look like there are any brilliant insights being shared in the chat for this one. So when this patient was evaluated, there was, oh, looks like a couple are coming in. Some thoughts about the right lung, left hemidiaphragm looking a little bit weird. I like the fact that someone's wondering whether it's a normal film. That's always a really difficult thing when you're looking at films. You feel like you should always find something that's abnormal, and it's hard to just kind of commit to the fact that maybe the film is in fact normal. This film is not normal in this case, however. But I'm referencing some vertical lines. I think you're referring to these lines here. These sometimes, the one thing that fakes people out with pneumothorax is the scapula sometimes. And the way you can tell that it's the scapula as opposed to a pneumothorax are two things. One, if you follow this line around, it actually curves and starts heading back out towards the edge of the chest. Okay. Two is, notice I have lung markings. There's a line, but the lung markings actually extend to the other side of the line. You don't have lucency here, so that wouldn't make a pneumothorax. And then finally, this line is present on both sides. So that suggests it's a structure that's present in this patient normally, and those would be the scapula. The aortic notch is not easy to see. I would agree that that's the case. This patient's rotated a little, as evidenced by the fact that the spinous processes do not line up nicely in the trachea. And I think that causes the mediastinal structures to change in appearance. And as a result, you don't necessarily see the normal shape of all the structures like the aortic knob itself. PE is always a good consideration when you don't see any obvious explanations for someone's respiratory symptoms on the plain chest film. I'll tell you what happened in this case is they didn't see any good explanation in this patient, even though she had a pretty good story for what sounded like a pneumonia, dyspnea, fever, back pain over just 2 days duration, could be pneumonia. So they got a chest CT, and when they got the chest CT, there was no pulmonary embolism, but there was this very, very dense area of opacification behind the heart. And it turned out that this patient had a retrocardiac opacity. This was the pneumonia that fit with the clinical symptoms. So one of the things I want to leave you with as we conclude is when you're looking at a film, don't forget to look at the retrocardiac space on a plain chest radiograph. In the normal situation, you should be able to see the aorta descending through the chest, clear border of the aorta just to the left side, patient's left side of the spine. you should be able to follow the hemidiaphragm all the way to the middle of the chest. And you should actually see lung markings through the heart because we have lung behind the heart in normal circumstances. If you look at this case over here, notice that here's the aortic knob. I can't follow it down behind the heart. I don't see the hemidiaphragm at all. And this is what's called the ivory heart sign. This is a very, very white, densely opacified area compared to the normal lung markings here. This tells you there's something in the retrocardiac space. That could just be atelectasis, but in a patient who has a good history for pneumonia or was at risk for aspiration, this could be where that pneumonia lies. If you go back to the patient's film that I showed you a little while ago, I can follow the aorta for part of the way, but right in this area, the aortic stripe disappears. There's a silhouette sign. And while I can see some lung markings behind the heart, I get this area of denser opacification here. Okay? So this patient just ended up having pneumonia rather than pulmonary embolism or other problems. And a really good thorough read of the chest radiograph may have picked that up rather than this patient needing a chest CT scan. Okay? So with that in mind, here are some take-home messages for you. If you were unsure of the position of a line or a tube, do more in order to confirm that position. And in particular, with central venous catheters, you can either transduce a pressure or order simultaneous blood gases off of the line and a known arterial site. Remember that common problems like pleural effusions or pneumothoraces can actually have atypical presentations on chest radiographs, particularly when the patient is not in the usual upright position that we think about with most chest radiographs that are done. And you can use ultrasound, repeat imaging in either the lateral decubitus or upright position or CT if you're unsure of the findings that you're getting on your plain chest radiographs. And then finally, be systematic when you read films. Just like you are when you read an electrocardiogram, stick to a system and use it every time. It's going to help you avoid the problem of the satisfaction of search, where you identify some obvious finding, shut off your brain and don't identify less obvious things that may actually be more important or just important clues to what's going on with the patient. Right? Being systematic allows you to pick up all of the key things in a film. Okay? So with that in mind, I'm going to give you one last message, which is use the radiologist. Talk to them. Don't just read their reports, but actually pick up the phone and talk to them or go down to the reading room when you're unsure about what you are seeing or just to confirm your own impressions so that you can build your skills in this area. And with that in mind, I'm all done. I thank you for your attention this morning and wish you the best of luck with the remainder of your internship.
Great, thanks so much, Andy. Would you mind advancing one more slide? It'll give everyone the QR code for the evaluations today. So before you sign off, everyone, please take a quick second to scan the QR code to do evaluations.
And I think, Gabby, there was one question that came up on that last case, if you want me to just hit it.
Yep.
Kevin asked, would a lateral film have been easier to see this?
Yep.
If you're able to do a lateral film, it is in fact going to confirm the presence of an opacity in the retrocardiac space. I think the issue is, particularly like in the emergency department setting, a patient may not be stable enough to go for a upright PA and lateral. They may do an AP film in that particular case. So if you can, yeah, that's a much better way to do it than a CT scan.
Great, thanks for picking up on that question. All right, everyone. So again, thank you so much for joining us this morning. As you're doing your evaluation, I just want to mention a couple of quick things. A reminder, there was an attendance QR code at the beginning. If you weren't able to scan that and have not yet emailed me or sent me a chat, please do so I can make sure to record your attendance, number one. Number two, want to give you a quick heads up about next week. We've had a change in the schedule to try and accommodate talk about COVID, which is new this year. And the talk is going to be geared specifically for your learning. And it's going to include both clinical pearls and a intro and review of some of our basic policies and procedures, protocols that we want to make sure that you all are aware of as you are entering intern year. That's going to be a talk given by Seth Cohen. And so the schedule for the rest of the year will be adjusted just slightly. We're going to move Ken's talk to a separate slot at the end of August. So you will get all the talks just in a slightly different order. And I'll make sure that the website gets updated with that. And as always, if you have any questions, please feel free to email me, send me a chat, and we'll see you next week. All right, I'm gonna keep the Zoom open for just a minute so I can record everybody who's sending me chats. But otherwise, thanks for your attention this morning.
Gabby, did you get the chest radiography resource for them?
I will send it in an email to them from your slides because I have your slides. I think that's probably the easiest way to do it, but let me see. If you want to paste it into the chat now, feel free, Andy. Otherwise, I will send it in the to the listserv.
Yeah, okay.
I just can't control the screen at the moment.
Yeah,
There we go. All right. Okay, Andy.
Yep.
It looks like we're good.
Good.
Timing was great. I think the polling went great. Any thoughts or questions?
No, I think it seemed to go pretty smoothly. I think the polling is, once it's set up, having had familiarity with it now, it's generally fine. I think you always have to remind myself to like stop the sharing of the poll and et cetera. But that works pretty good. And I think what I found, and having a couple of other these things, I think the polling works much better for getting people to commit to an answer than getting them to throw things into a chat.
Yep. I totally agree. And this was actually really helpful for me because
did you stop recording, by the way?
Oh, I'm sorry.